Hey guys, welcome back for another episode of the AltMed podcast. My name is Andrew Dowling. I've got Mitch Kurtz with me, as I always do. How you doing, Mitch?
Yeah, well, thank you.
And we've got a return guest, which is a little bit novel for us. We have done it before, but sometimes when we have a great podcast the first time around, we end by saying, "Oh, we should really do this again." And sometimes it happens, other times it doesn't. But today's one of those times where it has happened, and it's my pleasure to reintroduce Dr. Nic Giumarra back to the podcast for round two. How are you going, Nick?
Yeah. Hey, Andrew. Yeah, I'm really good. Thanks. And hi, Mitch, as well. Yeah, it's
Um,
it's nice to be back, actually.
yeah,
It's
well, I
a
can't
lot's
remember.
happened since
Yeah, has it been
the
about a
last
year
time.
since our
Yeah,
I reckon?
I think it was July or August last year. So it's
Right.
been over a year.
Yeah.
Because I remember I recorded that one in Melbourne, because we temporarily moved back, but now I'm back in far north Queensland. So I remember where I was when I recorded it. So it was about
You're
14 months ago.
back on
You're
regular.
podcast 70, and now we're up to 110. So almost. I was going to say halfway ago, but not quite.
Yeah,
Well,
right.
anyway, but the point is,
Yeah.
in our industry, that period of time is
Oh,
like an echelon, really.
Dog
it's
years.
it's it's a It's amazing. I was talking to some friends in the industry who I only met last year at UIC. So that was, I think, May 2022, and now we've set up the a compassionate access program, like a centralized one. And I was chatting to them, going, "Oh, geez, I've known you guys for years." And they're like, "No, we haven't. We've known each other like 13 months," and it does feel like that. Like I probably haven't known you guys that long either, but it feels like a long time, doesn't it?
We are I
Mm.
won't give the exact date stamp because of when we release this podcast, but I'll just say to our listeners that we're recording this in late 2023 and on the cusp of
Mm.
staring down the barrel at 2024.
Mm.
And
Mm.
I'll just kick off this podcast today because we don't need to do your background. We did that in the last
No,
episode. For anyone who wants to
sure.
listen to that, jump back to the first Dr. Nick episode. But I just want to start with a statement, and you can agree or disagree. But I will say the current clinical practice that we're seeing by doctors around Australia in treating patients with medicinal cannabis is perfect. Discuss.
Perfect is a strong. I wouldn't say it's perfect. I would say it's very mixed. Um, Very mixed, what people might get, and that's not necessarily a problem. I guess it depends what the patient is seeking.
Right.
Um, so I mean, it's funny in my clinical, what I've learnt about this medicine and how to use it, and the plant itself has just come away leaps and bounds in the last year, and we can talk about that a bit. But yeah, it's definitely mixed. There's some, like, I mean, I do, for example, and the doctors at my clinic, One Health, we do long consults, sort of 30 to 40 minutes at least, to really get to know people and work out how to prescribe things. And then I see lots of patients who um, come to me saying that they maybe had a chat with a nurse, maybe filled out an online form, spent 2 or 3 minutes with a doctor they think was a doctor, given scripts that they didn't understand, and um, and were left just really confused and baffled and not really knowing what to do. So I think that's sort of the spectrum. And I'm not saying we're the best. I know there's lots of great clinics and great doctors out there, but it's a very mixed bag at the moment.
Yeah. Well,
Mm.
talk to us about suboptimal clinical care from a
It's
prescriber's perspective.
it's I think what the bigger issue in the industry, and we're sort of alluding to that off camera now, is there's almost two different streams of patients. There are some that are, and they're both fine. Like, I'm not being judgmental at all. So there's definitely the medical patients. There are those with, mostly we write scripts for pain, mental health, insomnia, inflammatory disease, PTSD, cancer symptoms, autism, epilepsy. Like, there's the true medical patients who are seeking a medical solution, um, and really want to understand how to fit this in with their existing treatment, their specialists, their lifestyle changes, and need more wraparound care. Then I think there's probably a lot of, I mean, we know that cannabis is probably the most commonly used illegal drug in Australia and probably around the world. And I think a lot of, and that's fine. I understand that people use it. And I'm not judging that at all. People have a right to access this plant, right? I think a lot of those people are then don't want to do it illegally. And so they want a legal option. And so I think what I suspect is that then there are some clinics or perhaps sort of websites that are set up and people can access legal cannabis quickly and easily and cheaply, because they don't want to do it illegally. They want to know what's in it. They don't want all the pesticides and other chemicals or hydroponics. So they want a legal option, but they don't necessarily want a medical option. Which again, like that's fine. But I think that my real concern is, and I just see it, I guess, and I'm probably biased because I see the patients who want the medical care and they don't get it from a tech company masquerading as a medical practice. So I think you've got these two streams of medical model. One is medical, one is more of an online tech-based shop or something like
How
that.
does it?
What do you guys think?
I think
Yeah,
I think it's interesting. Like we think of some. I think it gets confused both ways. So I think you have genuine patients who may or may not get the best care that they're looking for. I would argue that there's also patients that go to consults with doctors who would take 40 minutes to give them a consult and also not get the care that they need in some circumstances.
True. Yeah.
And then on the flip side of that, I think you've got also, for lack of a better term, recreational patients getting caught up in very medical outfits that don't really want to be there and are maybe falsifying scenarios or just getting CBD when they're really looking for THC. So I think you've got a mix up of patients both way, which reflects back on kind of the problem we have with the framework that this has been
exactly
shoehorned into.
That's what I was going to just highlight, is that there would be people listening that are just like, well, hang on a second. Surely a doctor doesn't go to med school for 6 years. I don't know how long it was, Dr. Nic. Maybe you can give me the background there.
It depends. Medical school itself, for mostly it's postgraduate these days. So you do your first degree and then postgraduate is 4 years, and then specialty training can be anywhere from 4 to 8, 10 years or so.
So between those three things, you kind of...
It's a long time.
It's a really long time. And people would be asking the question, I think quite rationally, that why would a doctor risk their registration with APRA, their ability to practice, by acting upon these things? Have you but the thing is, clearly,
it's a great, I think there's two things. Yeah, I know what you're asking. So why would a doctor practice suboptimal medicine? First of all, I think some people don't realize they're practicing suboptimal medicine because they don't realize the potential that this plant can have for like healing. And two, these, and I've spoken to lawyers and things about this, saying, as my role, since I've spoke to you, I've become in the leadership team of the Cannabis Clinicians Australia. So we talk about these things and concerned for the industry. And the interesting thing is these clinics, they're not doing anything illegal, right? And patients and the doctors aren't medicine. Look, I maybe not all the time, but again, I don't want to be critical of them because it's such a subtle plant, and I've learned so much as I've gone along. And it's almost the more I learn, the longer my consults get. But then nothing is going. If a medical patient, the only way these things really are going to change, if a patient has a really sort of negative, suboptimal experience, and they report it to their state-based healthcare commission complaints person, and then I think you require evidence. So it's a very tricky system. As far as APRA goes, I don't believe a lot of these people are doing anything wrong per se. They're prescribing within the legal frameworks. And I've also been told some of these clinics are actually exist outside the bounds of the TGA or APRA because they're not actually medical. They're business people who create a website with an ABN, and they hire doctors. And so they're not a clinic, they're not a practice, they're a tech company. And some of these people openly boast that they're fastest growing tech company in Australia and things like that. So they're not with APRA have no say because they're not, it's not medicine. So,
but also,
again,
it's fair to say that, like, I mean, APRA, it is interesting. I have been hearing around the traps that APRA has increased its investigation and enforcement. And I suppose, to your point, nothing really happens until a doctor breaches their Hippocratic oath. So if the patient actually is harmed and they can provide evidence on it.
Yeah. And unfortunately, I suppose when we're dealing with cannabis, I don't think people are, I mean, as we know, it's very safe. People aren't dying. People, like the opioid crisis. So we're not getting those really dramatic, explicit harms that are causing stats. I think people are probably not getting the best care. They're not getting the real healing potential of the subtlety of the plant because they don't understand how to use it. And so there's not a harm. It's more about suboptimal care, I think. And that's what when my patients come to when patients go to other clinics and they come to me, they just don't they're just confused. And it's almost, you need this whole different paradigm to understand how plant medicine works. And that takes time to re-educate people. And
do you have an issue with people, say companies that, for lack of a better term, wave patients through for patients, or for quote unquote patients that are looking for a recreational outcome? Does that irk you, or is that something that you're not really neither here nor there on?
Yeah, I guess it used to more, but then I think, oh look, then I mean I wouldn't want to see. We'll call them recreation patients. I don't think it's the right term. It doesn't quite encapsulate, I think, what people are doing. But for simplicity, we'll use that term. As adult use patients, or are they self-treating?
Yeah.
I don't quite know if we've really landed on the best term for it, but we'll call them, just say, recreation users. I know if these people see me, we sort of clash. Like, I'm working in the medical model, and they don't really want to buy what I'm selling, my paradigm. And so there's this clash. So in that sense, I'm happy for them to go somewhere else. My real problem, I guess, is twofold. One, the true medical patients that don't get the care they need, then they might use cannabis and give up on it, and they'll say, oh, it doesn't work. And they'll go back to their GP. I tried it, it doesn't work. Then it only confirms to the GP, oh, this doesn't work. Or the patients will tell their GP, I was seen by 2 minutes. And so then we've also got this growing list of GPs, pain specialists, neurologists, pediatricians who are not coming on board with how we're using this as a medicine. And and it's really important this spreads throughout medicine, medical school education, and to the specialties. So my concern is we're shooting ourselves in the foot as well, because we're practicing this way. But in the true sense, providing a legal avenue for a rec user, I don't actually have a problem with that. It's these flow-on effects that I think are problematic.
But could you not make the argument that patients, the genuine medical patients that are coming to cannabis, are coming because they have tried like traditional medication and that hasn't worked? So it's like, I don't know if it's cannabis specific or not. So, and I'm just asking the question to you. So, for example, you have a patient who comes and finds opioids, but after a while that doesn't hit as strong, or they have addictive properties, or find they're having side effects. So, like, you know what I mean? Medication not working for somebody because they didn't find the right one is not specific to cannabis, in my mind, at least.
That's true. I think it does work, though. I think it does, and when it should work. And if my patients come back to me and they say, "Oh, it doesn't really work," I go, "Okay, there's something. Either they're not on the right strain or cultivar or dose, or they're not." This is a whole nother conversation. This is something I've only really worked out in the last couple of months, actually, what actually particularly THC does at a neurobiological level, how it disrupts the default mode network. Do you guys know about default mode network? Other people spoken about that?
I have heard of.
More commonly spoken about in the realm of psychedelic therapy.
Yeah, okay.
So I think it's, again, and this goes into what I was saying about having cannabis as a different paradigm. So one of my favorite quotes is, and I can't remember who said it, but it says, like, if you want people to build you a boat, don't give them hammer and nails and instruct them to build a boat. Sell them the vision of the endless ocean. Meaning that give them the vision and they'll design the boat themselves. So, and that's sort of where I'm at. I can imagine. So here's my vision, that patients are getting tremendous benefit in their pain, mental health, sleep, mainly. They're the most three common reasons, autoimmune conditions, from cannabis. So we're reducing human suffering. Like, we're in the business of suffering, okay? That load goes down. People are using, yes, less opiates, benzos, painkillers, which cause side effects, less accidental overdose deaths, less ED presentations. Fantastic. Then the GPs get on board. And instead of me fragmenting care and your patients coming to see me, GPs can learn how to prescribe it. Fantastic. Then the pain specialists get on board, stop prescribing these other things, start using cannabis as well. Fantastic. The neurologists are treating epilepsy. The pediatricians are treating, the self-injurious behaviors in ASD and a lot of the genetic conditions that really cause significant distress in families. So they're all on board. Now, all of a sudden, it seeps into the hospitals. Instead of giving people a temazepam or a Valium, they're having a bit of CBD, THC when they can't sleep on the ward. Then it's being taught in medical schools. It's being used in aged care facilities. So now you've got this medicine that is widespread across the board. It's everywhere. Imagine then if you're a company producing cannabis, like, I mean, from a bottom line approach, for a simple financial incentive, that's what you want. You want all of us using it. Then that's the point we've won. That's when we've really got a fantastic medical model of how to use cannabis across the board for patients. That's a long way off. Why is that? Because patients and doctors still don't they're looking at our industry thinking we're all a bit rogue. That's the problem.
Do you think, though, that, like, I know there have been a couple of outlier cases where APRA has, basically revoked someone's registration and ability to practice, but it's pretty rare. I mean, I'm just interested in your.
That's true.
Because
I get contacted by quite a few people now that I'm in this sort of position with the CCA. And people within the industry who are looking for doctors and treatment, who will go around and just can't get the treatment they need. I know there was a CEO of one of the companies who saw multiple. He said he saw I think 10 different clinics, like reputable ones that he thought he liked, and he told me this because he came back to me and goes, "Well, I'm just humble brag." He goes, "You were by far the best. You were the only person who really understood it." And I said, and he's like, and I said, "Well, that's great, but that's also really distressing. That's not. I mean, that's terrible."
But it's
so
indicative.
And I get this a lot. I get an email once or twice a week from people going, "I'm trying all these clinics and I'm not getting what I need." So they're not necessarily they're not necessarily doing something illegal. They're not doing something that can be struck off from APRA, but there's something wrong.
Does APRA have enough power, do you think?
Yeah, I don't really know how it works, unless, yes, they do if you are doing something overtly, like breaching the rules or the standards. But again, nobody's doing anything illegal per se. There's no rule saying how long a consult should be, how many scripts you can write, how many, what dose of THC. There's no boundaries on that.
But there are some, like in every profession. I'm a lawyer. There's plenty of bad eggs in the legal profession. In fact, it's hard to find good eggs sometimes. But was going to ask just on, I've heard some concerning things that I'm going to throw a couple at you and comment as much or as you want. But I've heard one instance of a doctor who left a large-ish clinic, and mainly because they were unprofessional in the way that they were, conducting telehealth consults whilst driving, not taking any notes, this kind of behavior. And was sacked, and on the way out took a whole lot of patient data from that clinic and started contacting those patients for their own new clinic that just popped up. I've also heard about, doctors who are alleged to be overprescribing flower, and in their part of the world, the hospital where they practice is a scenario where you're seeing a lot of acute
cannabis use disorder. I mean, I haven't heard of that specific case, and I have no idea who that is, but that just makes me sad, to be honest. I mean, I'm not here to beat up on any clinic or any particular practice. I don't think it's any one individual's fault. I don't think anybody who is necessarily explicitly, what is it? People aren't
just say that
trying to do the wrong thing. It's just, I don't know. It's almost the vibe of the industry, isn't it? What's acceptable within the industry becomes the norm.
But if you think that cannabis is, and I'm just playing devil's advocate here, so what I like to do on the show, but if you think that, cannabis works really well for most people, and let's say not everybody can get perfect care every time. I don't think that's true of any field within medicine. Isn't it better that in a nascent industry like this, people are getting mass access to something that's otherwise stigmatized pretty badly?
I've thought about that. Yes, and that's you're spot on. Yeah, I absolutely agree with that. If you look back, 2016, when this became legal in Australia, it was almost impossible to access. So much red tape. I think it's almost the pendulum swung the other way. Access now, I mean, people could get a script within an hour if they wanted to. The access now is more probably about price and cost, if anything. So I guess, yes, I agree with that. It's better to have access than not access. I guess we've just got to be careful that, like it's all about balance. The pendulum swung too far in the other direction, and then cannabis can be addictive. You can get subtle withdrawal effects. You can develop cannabis use disorder. You can have too much THC. I've certainly had patients who haven't followed their treatment plan, used way too much THC, ended up in the psych ward. There's slight increase in risk of psychosis. I think it's an odds ratio of 1.5 or 1.4 for young men. And interestingly, it happens in older women, sort of 40 to 50-year-old women and 20 to 30-year-old women. So these are risks. Like cannabis, often there's almost more like a confirmation bias in the pro-cannabis people that it can do no harm. But I don't think that's true either. So are we doing harm? Well, I don't think we're doing as much harm as the OxyContin crisis in America. But there's a risk. I think we just need to pull the reins back a little bit on it.
I think though we need a wholesale review of healthcare in Australia, because that drug you just mentioned, OxyContin. I mean that was approved by the TGA, right? And the TGA hasn't got any time for medicinal cannabis. So let's just get a bit serious, shall we? I think that we need to look across the board at the way medicines are being regulated, doctors and other healthcare practitioners are being regulated. For example, you talked earlier about how you will see these clinics pop up and the people that are behind it, don't come from a health background. I mean, that's not possible with pharmacies, because we have specific laws that say that pharmacies can only be owned by a pharmacist, be it pharmacist as a sole trader or in a partnership with other pharmacists, or even as a director and shareholder of a company with other pharmacists or themselves. but there is no way for someone who isn't a pharmacist to have any
That's right. Yeah.
ownership interest in a pharmacy. So, would regulators move to do something like that with clinics? I don't know. I don't even know if that solves anything, but I'm just throwing ideas out about the scope of what could be looked at in a review of the whole system that we're in.
Yeah, I agree. There's a crisis of general practice where patients can't get in, and bulk billing, and clinics closing down, so people can't access that. So they sort of coming to cannabis clinics. I agree. It's a widespread problem. Do we need adult use legalization where people can grow their own plants?
Yes. Sorry.
Um,
what I meant to say was absolutely yes.
Mm.
But yeah,
you did say that. You did say that.
But talk to me. So I just want to know, because you're much more at the coalface than Mitch and I are. We, sit in our offices and just do our thing without necessarily interacting on a daily basis with patients. But I just want to know, for some of the I guess the hotspots where you're starting to see overprescribing around Australia, and potentially some acute presentations at EDs. Is anything being done about that problem? Sounds like very few people are talking about it, but I'm just curious what's your take on that?
Right. My take on it is that nothing is really being done.
Right.
Not from a government. I mean, I've been in this sort of job now with cannabis clinicians for a year, and we're pretty vocal with, talking to TGA, APRA. They've never contacted us.
Yeah.
Right. We've written a code of conduct which we set out widely to the TGA, APRA, RACGP, Medical Board, the other cannabis college, the ANZ CCP, for review. Trying to we're trying to internally regulate ourselves, to be honest. Currently working on some like prescribing guidelines, talking to sort of key doctors and scientists in the industry, going, right, let's develop some guidelines. I mean, I get a lot of new doctors coming in going, how do I start? What do I do? Where's the structure? Where are the boundaries almost? And so, I mean, with the CCA, that's what I'm trying to do now. And again, these aren't enforceable guidelines. They're not legal guidelines. The way I see it, and working also, we're sort of building a relationship with the ANZ CCP, which is the other main clinical college in Australia. We're sort of just having those conversations together now, going, all right, well, what do we do about this? How do we don't want to stifle the industry. We don't want to stifle innovation. And I agree. And it's a really good point you made by there's a problem in the medical model. So having these other companies and business people, entrepreneurs come into the industry, does that freshen it up? Is that a great way of doing it? I mean, yeah, possibly we can get the best of both worlds. But at the moment, the way I see it is having some kind of guidelines or practice accreditation. Go, right, here's at least the agreed upon standards of what prescribing should look like. And I mean, I think that's probably the best start.
Well, and we now know there is a growing list of experienced prescribers. That number gets bigger every year. One of them is one of our favorites, the very outspoken Dr. James Stewart. That you're seeing, when he speaks on this topic about clinics and best practice, worst practice, there's clearly, doctors who are fed up with the way it's all going, and are kind of saying, you know what, there needs to be a change here. Again, I don't know if regulators are paying it as much attention as they could or should, but it's there's definitely also that list of outspoken doctors is growing every year as well.
Yeah, I think it's I agree. I think it's great. There's a lot of people that are they're passionate about this because it's a medicine that works. And you spend a decade or more, 14, almost 15 years in medicine. Doctors don't get passionate about Nexium or their antihypertensive drugs. This is because it just works so well.
Yeah, I love Nexium.
Yeah.
Sorry. Had to.
Yeah, I suppose when you
Yeah. Do you not? So you don't get passionate about like
needs to
statins?
be directed. Yeah, that passion in the industry needs to be directed, and the thing I've realized, and the thing that where I've sort of softened my approach is I don't want to think about it as like good people, bad people, good doctors, bad doctors, good practice. It's not quite right, because I think there's multiple, like I said before, multiple streams of patients and different needs in this. And there's obviously a marketplace that, and if people aren't going to these clinics, are they getting it illegally, which is perhaps poor quality plants or having other chemicals and ingredients which can make you sick? So is it the lesser of two evils? Well, it's very grey, all of this. And I think we're just at a point now where we're just all of us having these conversations are really important. And I guess for what I really would, one of my real agenda today was, if you're a patient, to make really good selection about what you want out of this and which type of clinic you need. And if you're really looking for a medical approach, don't just go to a website that has a book now option. If you can't see which doctors are there, then it's probably more like a website business rather than a clinic. Ideally, a face-to-face, nurses, harm minimization, like policies and procedures in place, long consultations. That's sort of what you're looking for. So I think just patients need to sort of be aware that there's just different levels of clinics out there, and to make good choices initially. And don't, I mean, for the initial consults, you probably need to be paying $150, $200, $250. If you're paying $30 for an initial consult, well, that company is making money elsewhere through their closed loop prescribing, which might be fine. That might be what you want. That's fine. But you're going to get a different level of care based on that. For example, recently the AMA came out with refined comments about how much a standard GP consultation should cost. So I'm not talking about cannabis here. Like, you go see a GP, 15-minute consultation is worth $101. Okay. So a GP could be billing, in theory, $404 an hour and people get the rebate back. So if you're seeing a cannabis specialist, a specialist doctor for 30, 40 minutes, and you're paying $30, something's not right.
Yeah.
Isn't it
There's some other
technically
agenda there.
you can't really call it a specialty, can you, though, per se, like technically, as you couldn't call yourself a cannabis specialist?
No. Yeah, no. It's probably not technically. I think I call myself it sometimes because
I get what you mean, but I mean,
to,
generally, you have to have a speciality, like by law, don't you, to be a specialist in?
Well, it's the national law.
I don't.
Yeah. Anyway, I actually take your point. It's a quasi specialty, because it's totally different.
I get it.
Of medicine that you would have previously been working with, single molecule.
Yeah.
It's anyway.
I have a question around because you were saying you really kind of especially of late have been honing in maybe a bit more on the THC side to find outcomes for people based on I guess playing more with THC than you might otherwise would have, call it 12 months ago. Can you explain just briefly the types of scenarios where you might use, say, a THC only treatment as opposed to, say, a balanced treatment? What would the benefits be on not using CBD in some cases and just using THC, if at all there are scenarios in which you would do so?
I basically, no, I didn't. Did I say that? I do have a, no, let me reframe it. I still cannot think of a scenario where CBD is not relevant. Because it is still, remember, the CBD, and this is oversimplifying it, CBD goes to your body. It binds to cannabis 2 receptors, which are on your body, the majority on your immune system, but also your joints, your muscles, your nervous system, your pelvic organs, your gut, your skin, everywhere. So the endocannabinoid system is all about balance and homeostasis. And people's problem, and all of us do this, all of our lives are out of balance because of Western society and how we live. So cannabis is about balance. THC binds to the cannabis 1 receptors in your brain and central nervous system, and fantastic for pain relief, sedation, and again, this default mode network, which I'll talk about in a second. But most people, if they have pain, you have pain in your body. And so the CBD is a powerful anti-inflammatory, is really important. CBD mitigates and minimizes any side effects from THC. And CBD also actually does bind to your cannabis 1 receptors. It binds almost to the side wall of it and does something called positive allosteric modulation. It changes the shape of the THC receptor and helps THC bind better for longer. So I cannot think of a situation where CBD, like a minimum, I think, minimum for most people, 50 milligrams CBD a day. Even if your pain's settled, your symptoms are settled, your headaches are gone, your skin rash, blah, if everything's settled, you still need probably 50 milligrams CBD a day. And the THC, what I've realized is and this was actually, this is something probably where I've come the furthest this year. And this is something I learned from my patients and just having time to listen to my patients. They would all say with a mild to moderate dose of THC, maybe a flower, 20 to 23%, quarter of a gram a day, half a gram a day, maybe only that much 2 or 3 days a week or something. They would say after 2 or 3 months that they just feel like a different person. They feel like they've been rewired, and their anxiety, and particularly for mental health, that they would feel that they're just rewired. They're like, I feel like a different person. I think differently. I approach situations differently. And I thought, there's an element of neuroplasticity going on here. And I looked it up, and there's mixed reports about whether or not THC causes neuroplasticity or not. But what I found was that, so it's going back to the default mode network, and the default mode network in your brain is a series of brain centers, and that become active when your brain is not, when you're not task orientated, when you're just sort of at rest, when you're daydreaming or driving the car, your brain automatically goes into default mode network, and you're basically retelling your story. What people think about is their identity, their where they fit into the world. They relive memories. They do future planning. We all get stuck in this default mode network where we're telling ourselves the narrative of our life. Agree? Are you with me?
I'm with you.
And so a lot of mental health. So if anxiety is, people sort of worrying about the future, perhaps oversimplification, depression, people kind of stuck in past things. I mean, there are certainly true biochemical depression, but a lot of it is this narrative of your life is a very fixed internal monologue. Most of us are overly self-critical, and our internal monologue is we're just beating ourselves up. Very simple, right? So THC turns down the default mode network. So when you have THC, these parts, and there's a part in your frontal lobe and your cingulate gyrus and your parietal lobe, it's these parts almost, they disconnect and switch off. So when you have a little bit of THC, that rumination, that internal voice gets switched off a little bit. I think if people have heaps, if you have a gram, 2 grams, if you have too much of a high dose THC, you become too impaired. It sort of switches it off too much. What I find is my patients, you switch off the default mode network, you're not having that internal monologue. It creates space for you to lay down new neural pathways, and it allows you an opportunity to retell your story, reconnect memories, thoughts, core beliefs about yourself. So if you have THC and sit down on the couch and watch a movie, fine, whatever. If you have THC and go out into nature, go for a walk, talk to a friend, see your psychologist, do some journaling, play music, do art. If you use it as a tool, so you've got this window, this 1 or 2 hour window where your default mode network is switched off, then you've got a chance to recreate your identity.
Yeah.
Right. And this is where, and this almost goes into Jungian psychology, where, you know, Jung talks about we've got the subconscious and the conscious mind, and then the collective unconscious. And so most of us are stuck in our conscious minds, and we relive, and we're stuck in the same problems. And pain, when you talk about pain, I mean, there's the true pain that you've got a sore joint or arthritis or disc bulge, but there's also the emotional, mental load of that pain and the story behind the pain, maybe some victimization, catastrophizing about things you can't do. I can't do this, I can't do that. So there's an emotional element of pain as well. So what I tell my patients is, when you're using the THC, if I give you some, if it's at nighttime, or some, you know, a little bit of flower for the anxiety or the pain, like you need to use that time frame really effectively and with intention. And it
Yeah.
can't be 27, 2 grams of 30% flower. Too much.
Yeah.
You can't engage and rewrite your narrative if you're that stoned.
Yeah.
20% of a balanced hybrid, small amounts when you're in the right mind frame, will change your life.
Yeah.
And to the point where my patients now say to me, actually, I don't need this anymore. I'm good. I'm fine. I don't need my psychologist. I don't really need this. I don't have anxiety anymore.
It's like
Right?
so they've done the almost the rewiring, root cause
Correct.
addressing. Yeah. Okay.
Yeah. Yeah.
Interesting.
And that's what shows, and that shows up in functional MRI scans. So if you put someone in a functional MRI, you can see these parts of their brain that fairly universally are all connected. THC switches it down. The other psychedelics switch it down a lot. You know,
Yeah. Okay. That's
so
good.
which is also why you have to be careful when people have unstable mental health, past history of schizophrenia, other substance use. If you're not connected to self, it can also be really dangerous. That's where people lose touch with reality and the difference between what's happening in the external world and their internal world. So that's where people can sort of run into problems as well.
Because
So it's not. Hmm,
I'm going out on a limb here, and I always caveat, of course, I'm like the whatever. If you could imagine a spectrum of, here's like a healthcare practitioner. As a lawyer, I think I sit right at the other end of that. So I'm not trying to offer a medical opinion, but I just curious, based on what you've said, would it be the case that if somebody is coming to you and they have, say, a history of mental health, or they substance abuse, are the markers that you're looking at there, you're kind of going, potentially this is someone who uses products in excess to escape that default mode network,
yeah,
that's basically they're living in their own misery when they're not affected by substances, because they're constantly being tortured by this inner dialogue that's telling them that they're not good enough, or it's their fault.
yeah, yeah, yeah.
Is that
I
kind
think
of
so.
the red flag
Yeah, I
that,
think so.
mm,
Yeah. And I think I think it's we all, I think we all do it to some extent. Like our negative, our self-talk is often very critical. It's almost like you need to flood your brain with positive, like ridiculously, absurdly positive self-affirmations,
yeah,
um, almost to survive. And I think we're all designed a bit that way. Like anxiety is almost default. I tell people the cavemen that didn't have anxiety, they got trampled by woolly mammoths and died. Like our ancestors had anxiety. Anxiety is a survival mechanism. But if you're stuck in that fight or flight mode, it's horrible. Like it's horrible, because that's your default state. And so that's where, yeah. And so I think what people do in that default state, it can be unbearable. It's torture. It's it's absolute suffering. And so if you have 2 grams of flour, you just knock it out, right? You almost dissociate. Great. But then as it wears off, you're back to yourself. And then you
yeah,
dissociate back to yourself. So the patients that I've seen, and this is, I didn't know any of this. I just saw this pattern. They'd just use a little bit effectively. They'd go to yoga class. They'd have a little bit before psychology. They would walk in, like the amount of people I've had with like depression. I go, okay, have a little bit and go for a walk. And they'll tell me that they'll notice the plants and the butterflies and the flowers, and someone will stop and talk to them on the street, and they'll go for a 20-minute walk, and they'll just feel a bit hopeful. Like, oh, the world's quite beautiful. And I spoke to my neighbor, and that little bit of hope is great. But if you have 2 grams of 30% flower, you're not walking around the street looking at butterflies. You're sitting on your couch passing. Like, so
Yeah.
this is where, and I hope people listening kind of take this on.
You do,
Because
like, you do appreciate the tastes of ice cream in that latter state that you were just describing.
yeah,
Um,
yeah.
but you're not, yeah, there's no real breakthrough happening other than, the seal
No.
of the ice cream container.
Yeah, yeah, yeah. But it also what happens as well, I've heard this from a number of people, that if you disrupt the default mode network, different memories can come up. And this is, I think, when people talk about their subconscious, tapping into your subconscious, it's almost like all those memories are still there. And sometimes they can be really difficult memories. Sometimes they can be really challenging. And the memories almost have this emotional energy to it.
Mm.
And so I've had patients that have said sometimes they've tapped into a state and they have a really hard night. It's like dark night of the soul kind of stuff. But then they also say by morning time, they're like, I get it. I can see it all. I've worked it out. I see where I fit in my life and why I think about myself like this because of this, this, and this is my narrative. And I realize my narrative is wrong. So let's go back to teenage years, substitute something there. And therefore, where I am now is I'm in a different place. It's quite so it's not easy. It's not a band-aid solution. Cannabis isn't a band-aid solution. If you do the work, it's not going to be necessarily pleasant. Like, I shouldn't say butterflies and talking to your neighbors. It can be soul-wrenching hours by yourself in the middle of the night as well. That's healing. That's the work. When people talk about doing the work, that's the work, and sitting with it.
Mm.
I should say, if you are going to do that, having CBD helps the default mode network reconnect. So CBD can bring you out of those states as well. So you have 50, 100 milligrams of CBD. It's the antidote. So again, I tell my patients that if you ever really, and particularly people who are doing the work, but they're a bit fragile, they're a bit brittle, but they've got support and family support and their doctor and me and their psychologist. But if I'm like, if it's too much, have big dose of CBD.
Yep. And that'll
So
take you out.
yeah, it almost reconnects you back to your default state, which is better the devil you know.
Yeah.
Reset the network back to default.
Yeah. So it loosens it. What happens? It's almost like it's like there's this knot in your brain that defines you, and it's almost like it loosens it, and then you can slowly untangle it and reset yourself, like rewiring. And yeah, 2 or 3 months I've seen people go, actually, I don't need this anymore. I'm good.
Yeah, that's amazing. And it's refreshing to have this conversation, because I think sometimes, many people who work in this industry at every level, nurses, doctors, suppliers, everyone, we go along to these conferences and we have this kind of bird's eye view of what are trends in supply and what are trends in sleep studies. And you feel in a way that the topic of medicinal cannabis can at times feel a little bit abstract, because it just depends on which angle you're approaching it from. But what you're describing is that process of somebody, meaningfully going about a course of treatment and actually, doing the work and getting results that ultimately make them more content as a person, achieving balance. And that's more interesting to me than sitting through a seminar on the TGA's enforcement priorities for 2024 or something like this.
It's still important, I think. And I mean, I've been to conferences where they talk about, I don't know, does beta carotene as an isolate terpene? What dose do you need it to treat osteoarthritis of your right little finger or something like that? I'm like, that's irrelevant. It doesn't work that way. It's not how it works.
Yeah.
And often, and this is where, interestingly, I think when they do pain studies, and the general, most pain studies, and there's hundreds, if not thousands, will all say cannabis reduces pain by about 30 to 50%. And even the TGA website says that. It says, the meta-analysis, it reduces pain by 30 to 50%.
Amazing.
The pain specialists somehow don't know about that, but that's what the TGA website says. But I actually think it's more, so it's 30 to 50. If you say to someone, how's your back pain? And they say, okay, I got 10 out of 10 back pain. And then you give them cannabis and you say, how's your back pain? And just say 30%. So they go, oh, it's gone from 10 to 7 out of 10. Okay. So a 30% reduction. You go, well, that's good, but it's not amazing. Even if it's down to 5 out of 10, a 50% reduction. Good, but not amazing, right? Better than most other painkillers. But that remaining residual 5 out of 10, when you're a different person, when you think about it different, when you approach life differently, when you're sleeping better, when you're more social, when you're more relaxed, when you're not catastrophizing, people don't care about that 5%. They'll say, yes, they've still got 5 out of 10 back pain, but everyone says it, but it goes to the back of my mind. Yes, I've still got 5 out of 10, but it doesn't bother me. Yes, I've still got 5 out of 10, but I can still do the things I want and I don't worry about what it limits me. I just do them anyway. So it's not a true number.
Yeah, exactly. But we love that. We love to just organize everything into strict numbers and scales and take this will fix that. Like it's very binary thinking.
Yeah, it is. And that's where we're going to struggle, like winning over the pain specialists, because imagine getting wacky Dr. Nic going to a pain conference talking about this stuff. They'd chase me out of the building, you know?
Yeah.
And so we're going back full circle.
So they chase you out of the building and then they'd return to their clinic and start prescribing people opioids, because that worked out really well, didn't it?
Yeah. Look, no, well, to be honest, the pain specialists do not prescribe, like they really don't prescribe them anymore. They're very strongly trying to get people off them. To their credit, we know they don't work. But the problem is then we're not left with many options.
What about Ket?
So they should. God, if I was a pain specialist, I'd get on medicinal cannabis. It'd be the most satisfying career. Your patients would love you, and you would actually really help. But so going back to this, just full circle, doctors in these clinics providing suboptimal care, they're not intentionally providing suboptimal care. They're working so fast, seeing so many patients who are only paying $30 for their consult. They don't know about this. Not many people know about this, because this is kind of cutting edge stuff that I have the luxury of, because I slow down my work and have longer consults, that and I'm really interested in this sort of human consciousness sort of stuff that they don't know people don't know the potential of what we're dealing with here, you know? You know,
does that
so
also,
they're not, yeah.
Does that also translate? Do you also have the same kind of love of potentially, well, I don't know if you've done any yet. You probably haven't, because you need to be a psychiatrist, but in terms of interested in psilocybin and MDMA and these other therapies that have been approved?
Look, potentially. At the moment, it's almost unrealistic for me, I'm a fully qualified GP. At the moment, only psychiatrists can potentially prescribe it. The model of it is it's tricky with psilocybin and those things, because when you take them, you know, you undergo an 8-hour treatment. You need a whole medical center supervision. You know, how if people don't want to pay more than $30 or $50 for a consult, how are you going to pay for a psychiatrist or a psychologist to sit with you for 8 hours while you're on a journey? How much is that going to cost?
It's almost as though
$10,000 a trip. It's out of my frame of reference at the moment. It almost doesn't exist. So
but do you feel
I don't put much
like they may have actually deliberately designed the access barrier to be super high? I'm just curious.
Well,
yeah, it's
for the psychedelics.
Yeah, like it sounds like they've got a very small group of potential patients in mind with the way that it's been. Anyway,
Yeah, I think I don't know. Look, I don't know that much about it, so I can't really comment. But I think I think these are very, they're full on medicines. Like you tap in, you knock out your default mode network. When people sometimes talk about ego death, or they feel like they're going to die, what it is your default mode network is like your ego. That's your sense of self. And there's a particular part of your brain called your insula, which makes you feel like you, and you as an identity, and you within your body. And if that switches off and you feel like you don't exist anymore, it can be terrifying. And then if your brain starts to connect, and memories and things you haven't thought about for 50 years all start connecting up, like this is really full on. This is not a,
Yeah.
so
Mm.
I sort of don't see how. I mean, I think it has to be rigorous and thorough and very carefully thought out, this whole thing. I'm not quite sure how and because when you take the medicine, it affects you for 8 hours. The LSD and MDMA and things. I'm not sure. I'm not sure how we're going to integrate it in. But my thing is, if you use THC correctly, which is intentionally small doses occasionally, with basic things like walking in nature, writing, creativity, play, yoga, you could, I don't know, maybe we can get the same effects. We don't even need to be talking about LSD.
Yeah, well, in the
I
sense
don't know.
that both of them are medicines that attempt to switch off that default
Yeah,
mode. Yeah.
yeah. We're rewiring the brain, right? And if cannabis can do it, and you control it by how much you inhale, and if you've got an antidote in the form of CBD, and you can do it
Mm,
slowly, gently, for most people, I mean, what an incredible medicine here. But how do you fit even that, and what I'm talking about, that into a medical model and into a 10-minute GP consultation?
yeah.
So do you need cannabis specialists? Yes, no, maybe. Depends what you want. It's what different we've got different streams of things going on, right? So, and that's the discussion. And that's, I guess, at the end of the day, when patients book into a clinic or a researching clinic, I think that's my message. Just be aware of which clinic you actually want to see. So
Totally.
if someone's a rec user who wants 2 or 3 grams a day and they're listening to this, don't come to me. I'm not the guy, right? I don't mind if you go somewhere else, but we're not gonna get along. We're not gonna, you know.
Yeah, you're more inclined to, do the full analysis. And
Yeah,
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 look, there are clinic offerings for exactly that type of
that's fine,
just
and that's
described.
fine.
To
Yeah.
each his own, or their own, I should
Mm,
say. Now,
mm,
I think we might be out of time, Dr. Nic, but it's
mm.
an absolute pleasure, and we love hearing from people at the coalface. It's as I say, it's very different to our experience, and I'm sure we didn't even sort of
But yeah,
unpack any particular de-identified patient stories. But I think it does sound like, you're even through the course of your own prescribing, you're expanding your own knowledge year on year. So you're probably a
yeah,
better
yeah.
prescriber now than you were when we had our first chat.
Absolutely. Oh, absolutely. And I'm better than I was 3 months ago. And even it's funny, if I see a patient from January this year, I'll look at their treatment plan. I'll go, why are you on that? And they're like, I don't know, you put me on it, Dr. Nick. I'm like, oh God, it's my January thinking. It's constantly evolving. And I mean, this is where doctors and the growers and the farmers and the people designing new technologies to, devices that people can inhale it from, like the pharmacists, we're all in this together. We're all like, if we all get along and collaborate and share our knowledge, um but this doesn't happen in medicine.
Yeah.
I'm not talking to the guy that manufactures Nexium. Maybe I should be. Maybe we should get him on the potty next time. But like, what we're doing here is
Interested.
really pioneering,
Yeah.
and it's a small enough industry that we get together and we can talk it out and learn from each other. And I think Australia can lead the world in this. Like, we're lucky that we've got the medical model at the moment and not really that widespread legalization, because I feel like if we had the medical model for a few more years, we can really work out how to use this as a medicine. Then
Yeah.
we can share it with the world. And then if we legalize it, fine. We've at least got that knowledge. I'm not against legalization, but I just feel like I want a bit more time
Yeah, there's a few people who
to
have said
work it
that.
out.
It's just a bit early now.
Yeah. Mm,
It's I understand where you're coming from. But no, yes, we could. All right, we could go for
yeah.
several hours.
Yeah.
As always,
Yeah.
me and I love a yarn. But no,
Yeah.
thank you, Dr. Nick. We
Yeah.
always
You're
appreciate
welcome.
your time and your insights, and hope everything's all good up on Magnetic Island. You're back in paradise, and you're looking a little bit tanned. You're looking well. Yeah, life must be
Yeah.
good.
Life's pretty good. It's very dry up here. It hasn't rained in months, and everything is extremely humid and dry. It gets a bit intense this time of year, to be honest. So it's less paradise, more survival, to be honest.
Very good.
All right.
Well,
Great to see you guys. Thanks for having me back.
no, thanks, Dr. Nic.
Thanks, Nick.
Speak soon.
Okay.
Until next
You're
time.
welcome.
Take care.